Hey, good morning, everyone, and welcome to the first annual conference for Big Sky Care Connect. We're so delighted to have you join us today. So make yourself comfortable because you're going to have a wonderful day of learning lots and exploring new ideas and sharing the vision of what Montana modernization of healthcare can be. So to start, I'm going to give a few opening remarks and just do some logistical pieces. And that includes just asking you to make sure that you're muting your phone and muting your computer so that that doesn't disturb the presentation for other folks that are participating today. And to also take advantage of our chat room. We've got the icon up above that you can grab onto, and if you have questions, just hit that questions and answers button, type that in, and at the end of the presentation, we'll have the time for those questions to be answered. And we look forward to doing that and sharing with you the wonderful news of where Montana has come in regards to establishing a statewide health information exchange. Now, this exciting news started just back in 2016. That seems like quite a while ago, but it actually has been a pretty short runway in regards to getting a health information exchange started in Montana. I want to thank Governor Steve Bullock, who really started off the conversation when he had an advisory committee formed that took a look at how we could improve healthcare delivery system in Montana. As they looked at different models and ways of doing that, the one common theme across was the need for data. The need to know where we can improve, and the need to know where we need to put our resources. So from that advisory council, a committee was formed to take a look at a health information exchange. In December of 2016, we launched a statewide conference, and individuals from across the state gathered at that conference and in the next year for a feasibility study. Over 300 Montanans involved as patients, employers, and healthcare workers helped us take a look at answering the question, is it feasible to have a health information exchange in Montana? And the answer was a resounding yes. And because of that, stakeholders got together and gathered in January of 2018 and formed Big Sky Care Connect. Now we know lawmakers, and I thank the lawmakers who are out there and who joined us today, because they oftentimes say, we need something to work with a broken system that we have right here in Montana. And the best individuals to fix that system are those that are working in the system. And we took that to heart. So we have a fine group of stakeholders that eventually came aboard of governors. And those individuals represent stakeholders from across the healthcare stream, also patients and employers. And we put together a governing board and a pathway through a business plan in 2019 to get us where we are today. Now, just a short few months ago, back in March, we signed a contract with InterSystems. Now, that's one of the top healthcare in technology infrastructures in the nation, and we wanted to make sure we had the best in Montana, and we're proud to have been able to work with them just since March. And by the end of the year, because of the hard work that you're going to hear about today, we'll be launching a health information exchange right here in Montana. And so with that, I thank everyone for joining us today, for the work that all of you have been doing in terms of sharing the word about the health information exchange, all of you that have been on our committees, and those particularly on our boards. And with me today is John Felton, and he's the chair of the board. You might see his face and think he is a movie star because he's actually been on the news quite a bit. He's the health officer over at Yellowstone County, and unfortunately with our COVID pandemic, he's had a lot of news time. But he also is a fearless leader for our board of directors. And with that, I'm going to hand it over to John, and he can talk about the agenda and move forward to talk about what you're going to see later on today. Thanks, John.
Good morning, everyone. Thank you, Jean. It is indeed a pleasure to welcome all of you to our first annual conference for Big Sky Care Connect. As Jean said, I'm John Felton. I'm the president and CEO of Riverstone Health, also the health officer for Yellowstone County, which is proven to be quite an active position for the last 8 months. And I also have the pleasure of serving as the current chair of the Big Sky Care Connect board. So again, the COVID virus. As a health officer for Yellowstone County, I know what you have given both personally and professionally throughout this pandemic, and I thank you for that. I also know that you're supported by great teams and leaders within your facilities and organizations, many of whom have joined us today in this virtual meeting, and I thank them as well. Each one of us can likely share a story related to the pandemic that shows the importance of creating care connections. Similarly, our conference theme will bring each of us together in multiple ways. Let's face it, it has been a tough year for everyone. More so, it's been a very tough year for our patients who have tested positive for COVID-19. The medical knowledge is evolving, continues to evolve, and our approaches evolve with them. We know the symptoms, we know who's most vulnerable. We also know that the need to reduce the risk of exposure to keep patients with chronic disease away from, has kept our patients with chronic disease away from their medical providers, creating a whole new level of risk. We know that the loss of social connectedness and the absence of the simple certainties of what we experience as everyday life has affected everyone, causing new levels of personal and social anxiety, which have been manifested as increased behavioral health needs across our state, our nation, and the world. For these patients, it is past time for a healthcare infrastructure that connects Montana. Each one of our providers should have access, immediate access, to their patient's full medical record. It's past time to throw away the fax machines and the days of wait, and instead be able to access vital medical records securely using the technology. We deserve better, and our patients deserve the best. The Health Information Exchange is your tool and a pathway to use technology and data to drive improved patient outcomes and increase provider and patient satisfaction in Montana. We've all heard that Montana is a small town with really long streets. This Health Information Exchange offers the unique opportunity to turn our widely dispersed healthcare providers and organizations into electronic neighbors. I want to thank the board of directors for the hundreds of hours that they have volunteered because they believe in achieving the quadruple aim of healthcare. There are not too many boards that meet twice a month, and we did that to get this job done. We did it because we know what it means to our patients. Let me share a few of the success stories of how HIEs are an effective tool in making this happen during these times of addressing the pandemic. The Health Information Exchange, or HIE, for the greater San Diego area is helping EMS personnel know when they are en route to a COVID-19 positive residence. Another HIE is sending daily alerts of positive and negative COVID-19 tests from labs to public health departments. And a third HIE is helping with population-level surveillance reporting, producing daily reports for state public health that contains registration events and relevant clinical information for population who test positive. Last, as we near the time of having a vaccine to prevent COVID, many states are looking to their HIEs as a key tool in this massive rollout. As the keeper, aggregator, normalizer, and connector of health data, America's HIEs have been able to aid their respective states and communities in this time of crisis. HIEs reach out to not only to connect hospitals, labs, and community providers, but also a continuum of community service providers and organizations that touch patients, including state and local government and social service agencies. Today, you'll hear from individuals who will share information on what that means and how it was achieved. So let's get started. First, let's cover a few basics, like what is an HIE and what does it do? Having a little trouble with the slides. Oh well. An HIE is an electronic health information exchange that allows doctors, nurses, pharmacists, other healthcare providers, and patients to appropriately access and securely share a patient's vital medical information electronically, improving the speed, quality, safety, and cost of patient care. Right now, Montana has a fragmented data system. As healthcare data on a single patient can be located in a variety of systems. and these systems don't talk to each other. In my hometown of Billings, a single patient might have sought care and developed records at Billings Clinic, St. Vincent Healthcare, and Riverstone Health, all of which are located within a 1 mile drive down 27th Street, and all of which have robust electronic record systems, yet each one of us only sees our slice of the healthcare information pie. This lack of interoperability and creates inefficiencies, increased costs, and increased risk to patients. The Health Information Exchange addresses this. It builds a bridge, an electronic pathway where information can be shared. It is secure, follows privacy laws, and connects a patient's healthcare team regardless of location. Big Sky Care Connect has tapped into one of the top technology firms doing this work globally, InterSystems, and your HIE is stood up and going through user testing by experts in that field. The HIE is new to us, but it's not an untested technology. Montana is one of 2 states who do not have a health information exchange. No more. By partnering with the best and leveraging the success of those HIEs operating across the nation, we will launch Montana's HIE in the coming weeks. HIEs now serve 92% of the United States population, and Montanans will soon get that advantage as well. It is an exciting time, and you are part of the success story. Also part of making this happen are the policy leaders, which brings us to our keynote speaker, Tom Novak. Tom is the Medicaid interoperability lead with the Office of the National Coordinator for Health Information Technology. He is an innovator whose perspective will set the tone and stage for a great day. So now it's my pleasure to introduce Tom Novak.
Thank you. John stole a little bit of my thunder there. I was going to do a little bit of all the great things that HIEs can do. But we'll still go into that. So, hello. I am, as John said, the Medicaid interoperability lead with the Office of the National Coordinator for Health IT. I work in the Office of Policy and I focus on state policy. I am also in a somewhat unique federal position in that I am detailed to the CMS Medicaid Data and Systems Group. By detail, it means I split my time, so I sit in 2 agencies. And as such, I'm then working directly with states and providing technical assistance and helping them, make good decisions on what to buy for interoperability purposes, what makes sense, what works with other providers and other states, that kind of thing. So I have been with the government for quite a while now. I originally worked on the meaningful use rules. I'm just trying to see if there's any eye rolling in there. I assure all of you that I am the kind of regulator who writes regulations for providers, but I'm also a regulator who is married to a doctor. So in the event I'm creating anything that's terribly burdensome, I will hear about it. So I assure you that if there's any cumbersome or onerous requirements or regulations, they are not coming from me. I feel like I just roll over in bed and confirm that I'm helping make policies that make sense for care coordination and the treatment of Medicaid patients. But yeah, I worked on some of the meaningful use regulations, mostly some of the Medicaid policy areas. Simultaneous to that, I had my first daughter was born, and she was born 28 weeks. So we spent 101 days in the NICU. In that time, I was sitting with my laptop in the NICU pod working on federal regulations around health IT, as I was able to look up and see the electronic health record that was, capturing various data points on my daughter. My wife had developed, for the clinicians here who might be curious, she developed HELP syndrome, and so sort of severe form of preeclampsia. So paying attention to a lot of these processes where they're writing things down on paper. They're writing down how many milliliters she eats, of milk or formula. All these things. Some of it is paper based. Some of it is manually entered, and just really paying attention and really getting an understanding of intense care coordination, like on the job while writing the meaningful use regulations. So, it became really, really illustrative because I then was in a position where I could imagine what I wanted as a consumer, as someone helping coordinate care, what would help me. So, we're sitting there, we're sort of glued to the pulse ox in the bay, always watching her oxygen saturation. And by the time she was discharged, we went home. She went home on oxygen, and we had a pulse ox in our house and an apnea monitor. It was very easy to imagine, hey, wouldn't it be great if, I had an app on my smartphone that connected to the pulse ox, so she could be sleeping in her room. But on my phone, I could set an alarm that says if the pulse ox got below 90 something, that I would get a ding, 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 and I could go check and just, make sure everything was all set. So it was really helpful to be in that position because I sort of understood, from the point of view of a consumer, the benefits of Medicaid technology. And getting into that world of health information exchange is where you really start to get innovative, where you start to think, okay, what can we do with health information exchange? Sort of problems that we can solve, or problems we didn't know we had that all of a sudden there's an intervention. So that was very helpful. I'm pinch hitting today for Jess Kahn, who's my former boss, who hired me at the time and was very flexible with me, teleworking and whatnot at the time, which was less common at the time. But a little late in saying this, but thank you for inviting me today. This is going to be really fun. I talk to states all the time. So I talk to state Medicaid agencies generally, but then a lot of the health information exchanges in the country. And I think that you all are doing the appropriate due diligence for health information exchange. You are not alone in being a state that has had a few false starts. That happens. Sometimes the market isn't there yet. Sometimes you don't have something that people want to pay for. Now, I think we are at a place with, value-based care and sort of the public health use cases around COVID and around the opioid epidemic really make it more and more obvious the needs that a health information exchange meets. So we're seeing more and more states be successful. There's been some attrition, though. There's been the good HIEs are surviving and thriving, and they're partnering with the vendors that make sense. They are going across state lines if it makes sense to go across state lines. So we're really seeing some maturing in the health information exchange space. We're also at a point where the literature is catching up with the technology. So we now have more and more published, peer-reviewed, published studies on the benefits of health information exchange. Okay, we all sort of get it, right? We understand what it does, but it's a little bit of a narrative that we sometimes struggle to justify because it's not inexpensive. And if you're thinking about things nationwide, you're like, do we really need to, have the ability to, in Billings, pull up the record of, someone in Kentucky? That's a lot of effort for something I will probably need to do once in my career, if ever, as a clinician. And I think a lot of the problem is that the use cases maybe haven't been articulated as well, that we haven't really thought through what we're trying to do and the problems we're trying to solve. It's become clearer and clearer that the health information exchanges out there that are succeeding are doing things that doctors want, that help providers, that help coordination of care. And a lot of times, and as a bureaucrat, I'm familiar, or I'm I guess familiar with the process of sort of just pushing down requirements to doctors and nurses and hospitals and clinicians, as opposed to working with them and seeing what they want. We really, in the health information exchange space, see the latter. We see health information exchanges that succeed doing things that are adopted by the providers enthusiastically, because they understand care coordination, they understand their patients, and they know what kind of data they want. And it's also worth flagging, they know what kind of data they don't want. They know, so the sort of wonky term is semantic interoperability. So it's not just interoperability. It's not just getting a 40-page CCDA record from one provider to another provider, because that does no one any good. Semantic interoperability is where we actually get something useful, where there is some technical process by which that 40-page CCDA becomes something that the other provider wants or needs. So the HIEs that are succeeding are good at that. And we're now seeing a lot of evidence. We're seeing that HIEs reduce the repetition of therapeutic procedures, defensible by peer-reviewed literature. And if you like, I can post links to some of these papers. I'm not sure how nerdy you all want to get, but there's some good literature out there that really defends a lot of the investments. And it's sometimes a difficult ROI to articulate when you're trying to think through the health information exchange, because it's kind of abstract, but the literature is more and more supporting all of these sorts of innovations. A significantly higher number of medication discrepancies were noticed when HIEs were used. So that's huge, right? The medication adherence rates in this country are astonishing low. There's financial factors. There's, rather sort of banal factors like transportation, like not being able to get places. Now there's COVID. There's a hesitation to go to the CVS. So all these sort of medication reconciliation needs can be automated and are reducing some of these errors. In the emergency department, we had a study that shows, thousands of dollars are saved by connecting health information exchanges in an emergency department. Before becoming a Fed, I was with the AIDS Resource Center of Wisconsin, so I've been on the provider side as well. I've not only been a bureaucrat. At the AIDS Resource Center of Wisconsin, I was the director of quality, and we spent a lot of time sort of thinking through how to coordinate care and improve care and the overall quality of care for our patients. And one study showed that when an HIV agency connects to their lab data via a health information exchange, so it's integrated better into their electronic health record, that all of these metrics improved, that the higher odds of antiretroviral therapy, better viral suppression, reduce sort of disparities in care, all because of that sort of automated integration. The labs are worth flagging, is this also sort of a low-hanging fruit for duplicate tests. So connected to a health information exchange, you find that you reduce lab tests, which are expensive, but you also reduce radiology examinations. There's a different study that shows if you use a health information exchange, you have an annual savings of around $32,000, $32,460 to be precise. But that becomes real money after a while, right? If your MRI, your CAT scan, if your advanced imaging study is, 4,000, 6,000, depending on your specifics, you knock out, if you do one less a month, you've maybe, paid for your bill for one of these sorts of, subscription services, or however your approach might be. So it's ROI, again, kind of difficult to appreciate, but it's certainly there, and the data is building. And then you sort of get to this point where you get to the sort of like the big numbers, right? Where you start reducing readmissions. And if you reduce readmissions, then you're looking at annual savings of $600,000 a year, or, there's other studies that show that, other studies that show, different numbers. But readmissions are huge. And in the Medicaid side, we're very sort of sensitive to this as well, because we look at that a lot in terms of new mothers, right? We have maternal mortality problems in this country, and connecting a mother who gets discharged from the hospital with a new baby to some kind of technology really not only helps with readmissions, but really helps with maternal mortality. And all the mothers might be sent home too early, or they develop complications, because we're seeing in our data that's a driver of some of these situations. And then we look at the list of the most expensive hospitalizations for Medicaid, and it's things they are conditions where technology can play a role. The second highest hospitalization reason for Medicaid, hospitalization cost for Medicaid, after childbirth, is septicemia. So I think Mr. Felton mentioned alerts briefly. There are some very modest technical interventions where various facilities have built a little bit of a prediction model and said, looks like this patient might be at higher risk for sepsis. And it's just a ding, ding, ding alert that goes off and says, maybe go do a sepsis workup on that person. Because with, the patient moving from ward to ward, being transferred, is maybe not always apparent. And those very simple alerts are saving lives and saving money. So very simple interventions there make sense. And these sorts of rather modest insertions into the workflow are yielding some good returns. So that's something that we look at. And some of the other things we look at on that list of the 10 most expensive things, there's a lot of opioids. There's a lot of substance abuse and behavioral health, where technology is maybe not the sort of the main driver, but certainly a complementary tool for care coordination when we look at connecting a state's prescription drug monitoring programs to a health information exchange. So you don't just sort of have opioid management as a function of law enforcement. You have it as something that is a network that can be connected to a social worker, connected to a case manager. If you have a patient out there not compliant, filling things irregularly, filling things too soon or too late, or sort of going from place to place, technology can help. Technology can help coordinate the care for that patient, and we're interested in that on the Medicaid side because we see some value there. Excuse me. So the use cases, I think, are really helpful for cost saving, but obviously, the communitarian spirit, of course, we want to improve quality and improve outcomes, and that really never became more apparent than with COVID. So, sort of moving forward, Mr. Felton mentioned the San Diego's EMS integration, and that's a good example, right? So that the providers out there, the EMS personnel, know what the situation is with someone with COVID, and there's so much technology can do here that really is only just now being explored. Some states have reached out to HHS to say we want to do more with telemedicine, and telemedicine, I think, in telehealth are sort of a term that's thrown around and people don't really unpack it. But there's a lot that can be done here. So telehealth, not only for the COVID patients, but for the non-COVID patients, so that they don't become COVID patients. Because, if you thinking back to March and April, we didn't know as much about what the appropriate PPE protocols were. And I just know this from my wife, that they were changing every day. And, it wasn't always clear, as we were all sort of learning at the same time. So it was prudent to stay home and, forego all elective procedures. But wherever you could do telemedicine, you did do telemedicine. And so all of a sudden we're trying to scale up telemedicine for the at-home patients who maybe it's totally unrelated to COVID. Maybe it's an asthma workup. Maybe it's something that is just, sort of a conversation with a clinician. So there's some great models out there that can lend themselves to Montana's landscape. There's some really successful rural telehealth programs like Project Echo out of New Mexico. Their model is they have an academic medical center that then has a telehealth connection to rural providers, and they sort of act as the specialists who virtually round on patients with, special conditions in these rural settings. So, if you have hepatitis and you're in a rural spot, or if you have HIV and you're in a rural location, getting access to a specialist is very, very challenging. Their model then has them go to their, rural family practice, and the specialist in the academic medical center rounds on them, and with the primary care clinician in the rural practice, and the metrics are off the charts. And it does a lot of things that maybe would not have been obvious. The primary care clinicians all get better. Like, they all get better, and it flips. The primary care clinicians then get better at treating that special whatever the special, be it, pain management or hepatitis or HIV. They get better, and then they start teaching the academic medical center personnel, here's what you're missing about this patient, or here's what I'm seeing. And the back and forth becomes great. The outcomes improve. The sort of the peer-to-peer collaboration is very encouraging, and both sides really benefit from it. And doesn't necessarily need to be Project Echo specifically, but those kind of mechanisms of using technology to coordinate care really make sense, and really also make sense as it seems like there's a lasting chronic component to COVID that we don't know enough about. And so thinking through how to manage that as a chronic condition for COVID survivors is going to become more and more necessary. There is, again, if you remember sort of early COVID, we had this time period where getting results was hard because, everybody's connected to Quest, everybody's connected to LabCorp, but nobody's electronic health record was connected to the CDC or to state public health labs, which were the first places, only places for some amount of time doing the COVID testing. We have partnered, we HHS have worked with the Association for Public Health Labs and built a free connection to state public health labs and the CDC can use from your electronic health records. It just needs an HIE to sort of enable it and sort of back it up. That really works. That makes it so that when you're an electronic health record, you go to order sort of any sort of public health type test, COVID or whatever the next COVID is, and it's the same standards, it's the same interface, so it looks to you on the EHR like you're ordering something from Quest or ordering something from LabCorp, because the interface is literally exactly the same. I think we talked a little bit about alerts. I think that's something that is very well coordinated at the national level, because we at the Office of the National Coordinator for Health IT have ensured that all electronic health records can do an alert. If they're certified, they can support an HL7 alert. If your vendor tells you they can't, you should probably reach out to us so we can talk to them. But it's really elegant, and it is, again, one of these things where we realize doctors really like it, because the most basic use case for it was something called ADT, admission, discharge, and transfer. We found out, which was not surprising, but we found out that a primary care clinician really likes to hear if one of their patients has been admitted to the emergency room, or discharged from the emergency room, or transferred from one facility to another facility. Getting that ding, ding, ding on your electronic health record that, hey, one of your patients is in the hospital is really helpful. And there are a lot of ways that alert can be helpful. Discharge instructions, like if you're a hospital and you're sending a patient somewhere else, packaging the discharge instructions into the alert and sending it to the post-acute care or rehab facility, or if it primary care clinician, or if there's a specialist, packaging up those discharge instructions in alert is very easy technically, and is a widely adopted use case. And in fact, is about to become a requirement to become a hospital. That was part of the CMS interoperability rule that was published this spring. Right before COVID, we published a regulation we've been working on for about a year and a half. So alerts are about to become much more mainstream, and let's think about incorporating them into our workflows in a helpful way. because this is good information to get. It's easy to send. But again, the key here is semantic, right? Ingesting that is going to be, needs to be done thoughtfully. Sending that discharge note to another provider is the requirements, but really where sort of like the market and the good HIEs jump in is, okay, how do I make that discharge note useful to the long-term care facility, the post-acute care facility, the primary care clinician, the specialist? So it's an opportunity. It's an opportunity to use a regulation that's compelling the hospitals to do this anyway to improve coordination of care for Montana at large. There are other sort of technologies out there that are being repurposed a bit for COVID in rather inventive ways. We created technology called Pulse, and I don't know if Montana is subject to wildfires as frequently as Colorado and California, but this technology is being used currently in California for their wildfires. This is called Pulse, the Patient Unified Lookup System for Emergencies. What this system is, and the HIE is the back end of this, this system uses a iPad or a tablet to essentially connect to every electronic health record in the state. That might surprise you. Interoperability is a solved problem. Like, interoperability is actually not that difficult. Connecting to every single electronic health record in your state is totally doable. It's always sort of policies and regulations and business drivers that are in the way. It's never actually the technology anymore. So Pulse is a very good demonstration of that. So what Pulse does is it gives the first responders that access that they use in an emergency. So if there's an earthquake, if there's a hurricane, if there's these wildfires where you're setting up a clinic in a gymnasium and you need access to the medication history of a patient so you know what to prescribe and what not to prescribe, what chronic conditions they might have, you can pull it up. And it's an elegant solution. It uses an existing provider directory that the state already has, that your state already has, already maintains. And the providers can log in. It's built to work on 3G. So in rural settings where you don't have Wi-Fi, it still works. So it's generally sort of packaged with some of our other tools we use for emergencies. We have another system we have called Empower, and Empower uses claims data to generate a list of all patients who might be electricity dependent. It started as a Medicare program, and now Medicaid is participating in it and in a few states. And what they do is they look at who's on home dialysis, who's on, going back to my daughter, who's on, various sorts of durable medical equipment around like apnea monitors and whatnot, or who might be on a, home ventilator, whatever sort of technology they might have. And then if there's a hurricane, or if there's a mass power outage, it lets all the first responders know, okay, this is the house I have to go to first. This is where we need to go check on these people, check on their supplies. We need to move them somewhere. And it's really, really easy from a technology point of view to stand that up, because we've done most of the work. We, HHS, have built the architecture. So what we're finding is that some of these emergency technologies are being repurposed a bit. So thinking through a future where we have to do mass vaccination clinics, having access to electronic health records sort of more readily makes a lot of sense, right? So if we're doing vaccines here, there, and everywhere, in schools and prisons, having Pulse, again, the sort of the iPad tablet portal makes a lot of sense. And some states are like, oh, we might, start considering making some investments in that and doing some research to see if that makes sense for, this future where we are needing to, vaccinate everybody, and going to vaccinate everybody in all sorts of different settings. because the COVID use cases are new ones are coming up every day. For example, another one is this sort of prediction model that some health information exchanges are looking at. So what they're doing is they will pull up all of the data on their patients, and they are able to find with a lot of certainty who, if they get COVID, will experience very, very negative health outcomes. And it's not just in terms of, oh, they have diabetes, oh, they have, other sorts of chronic conditions or, coronary conditions or obesity. They're also finding out, oh, well, they're Hispanic and they work in a meatpacking plant, or they're able to pull in more information. But they also then have this rich source of data where they're not going to get all the vaccinations that you're going to need on the first day. A state may very well have to come up with a vaccination, or does have to come up with a vaccination strategy. And having that vaccination strategy be data driven makes a lot of sense. Like, you then have a metric by which you're like, okay, here are all the patients who are going to be at the highest risk for very negative outcomes. It could be a complementary part of a state's vaccination strategy. So that's something that we have a few states working on that, and they're sort of adding data to it, because we're getting into some of the fancy machine learning and artificial intelligence here, when you're sort of playing with some of these algorithms to make them smarter and make them better at predicting who's going to have the negative outcomes. Going back to my Medicaid roots, we have a history of looking a lot at immunization data as it relates to children. So we have years of data on this. And one thing that is obvious is that whenever you integrate an immunization registry into an electronic health record, you have way better immunization rates. That sort of point of care access to the data is crucial, and makes sense that we're going to want to have high vaccination rates in the near future, right? So an HIE jumping in to play a role with connecting immunization registries to electronic health records makes a lot of sense, particularly when adult sort of non-pediatricians generally are not connected to immunization registries. There's usually not a business need to. It doesn't always make a lot of sense. Now there's a need to, and it's going to be a lot to undertake in a short amount of time. An HIE might be able to jump in and fill that need. Think about the care settings too that we're going to be looking at. Again, we were sort of talking about the mass vaccination clinics, but sort of even less dramatic than that are places like a long-term care facility or a post-acute care facility. Long-term care facilities may not have an electronic health record at all, or they maybe have a not very good one, or one that does not have any sort of hope of integrating an immunization registry. What do we do there? We are at a sort of a technology point in the sophistication of our technology, where we could do app-based immunization registry. We just have to slap a few FHIR APIs hither and yon, and we could be managing our immunizations from our smartphone, from an iPad. That might make the most sense when you're walking into the long-term care facility to give out immunizations. And remember, this is probably going to be, by all accounts, a 2-dose vaccination. That data coordination is going to be critical. Somebody's going to go to CVS, somebody's going to go to their FQHC, someone's going to get it at the hospital, someone might get it at school, who knows? So careful coordination with that data hub is really, really going to be driving the future. So a long way of saying there are too many use cases to count that the Health Information Exchange in Montana can roll up their sleeves and tackle. And I have a bit of an understanding about where you all would like to go. And philosophically, I think some might disagree with this, but I think it's worth thinking about. Isn't it almost like a utility? Like, shouldn't it sort of be like water or electricity? Shouldn't you turn on your electronic health record and just have data? Like, shouldn't it just be there, the data you need, the data that needs to move? There's sort of a growing argument for that in the government as well, that it just kind of makes sense that the data should just be there. And if that's really where we continue to move, then Montana's efforts will be prescient in having positioned yourselves as ready for that, supportive of that, and able to participate in it, both in terms of care coordination and both economically, because there's support for these at the national level and at the state level. So we think we're all on the same page. We think that we have a lot to work on together. And again, I just sort of congratulate you all for your partnership and involvement with the work being done here at the Big Sky Care Connect. I think this is a great effort. Like I said, I think you're doing it right. And I think I went a little shorter than hoped, but I have time for questions.
Great. Thank you so much for that. I get so motivated hearing you. And can you hear me okay?
Yeah.
Oh, okay, just making sure. Okay. Yeah, I get motivated hearing you speak because oh, okay. I get motivated hearing you speak because you have such vast experience. And it's exciting to hear what you've seen, the success stories, how clinicians and states and patients get involved in this. So thank you so much. So I do have a question, actually a couple. From your experience,
Sure.
What HIE services provide the highest value to provider communities?
So I think the alerts are high value. At least the providers like those a lot. They are really simple and high yield. And I know you're trying to make a buck here, but they're also pretty inexpensive to stand up alerting from provider to provider compared to some of the other more complicated use cases. Something really sort of administrative things that HIE helps with a lot. That I don't know if we have any payers in here, but a lot of payers get a lot of value out of partnering with health information exchanges. They're sick of paying the nurses to do the chart chases for HEDIS reporting because it's expensive. And why are they paying a human being to go, sit on the floor of a clinic and abstract by hand all of the charts so they can get their numerators and denominators? Payers are pretty excited to wait a minute, now I have access to an HIE that I can just pay them and they'll give me all this data, and it's all standardized anyway, so it works. So payers are really interested in some of this in a way that is maybe sometimes surprising. They'll do risk adjustment, they'll do other. They have requirements under some of the CMS rules as well, so the payers are getting involved. Sorry, we're sort of wandering off your provider question a bit there. But the providers also are very supportive of parts of the CMS rule. Like the AMA really liked that we were doing some efforts in the CMS rule to make sure that a patient's records follow them from plan to plan. That doesn't kick in for another year and a half, but providers and provider associations were really supportive of that, because that meant that if I'm seen by a Medicaid MCO and I move to another Medicaid MCO, that I have the right to have my data follow me. And it's specifically a HIPAA right. HIPAA gives patients the right of access. And it's specifically the right of access in the form and format you request. So what the CMS interoperability rule did was we sort of put a definition behind the form and format. We said the form and format I want my information is on my smartphone. And what that means is we are less than a year away from app-based access to our labs and immunization information, which seems rather handy at the moment, right? The providers also like that included in that regulation, this ability to move your records back and forth, because the providers are sort of sick of this sort of interplay between the payers that really seems unnecessary. Why are they always having to do these prior authorizations? Why are they always having to write letters of medical necessity? Why is it when my patient is in the pharmacy that they have to call me to fix a thing because the formulary says they need to try ranitidine before they get Nexium, and I know they had ranitidine. That's just, it's not in a record somewhere. Why am I involved? Like, they were on some other plan when they tried ranitidine. And automate all of that. That's easy. The format exists. The technology exists. Your record should just move with you, and it should just work, right? It should just, again, be like a utility. That information should just follow you. It should be a right. So providers are really supportive of that because we're really focused on reducing burden for the providers and having that information, that it's maybe more administrative in some cases, but it saves the providers time, and it saves them time to then focus on care coordination and not interrupting their day to get on the phone with CVS. So there's a lot of things out there, both existing use cases that the providers like, as well as some of these emerging use cases that are tied to, current rules and future rules.
Thank you for that. We have a few more questions, but I also wanted to remind those who are in the audience, feel free to use the chat for any questions that you may have. We have our expert, and so we'd love to ask any questions that are weighing on your mind. Our next question, talk about where CMS is going in terms of regulations that will affect HIEs going forward.
I don't know. I mean, I don't know if you watch the news. I'll let you know. But it's actually very apolitical interoperability. So it's really not terribly subject to sort of some of the more political things happening. That a lot of these efforts were started in the previous administration and continued in this administration. And we've already said that the first interoperability rule was one of what will be an ongoing effort to increase interoperability. So health information exchanges, I think, are really demonstrating their value in COVID in a way that is putting them on the radar a little more nationally, because we have all these situations where public health data just sort of falls into a bucket that nobody ever sees, right? Where, the CDC gets it and the state public health department might get it, but there's a lot of sort of well-intentioned state public health reporting laws that don't let that data move and coordinate care and sort of be of value. And the governors are like, why am I, like, the CDC is getting all this money to stand up these public health systems, but I want to do something with public health in my state. For the HIEs out there, this is a solved problem. Like, the HIEs have already inserted themselves into the mix. They already have sort of figured out the state level regulations or the state level requirements, and maybe they're a part of public health, or maybe they're designated a public health reporting entity. So they're sort of incorporated into the state architecture in a way that they are already doing what we're trying to do nationally in response to COVID. They're already moving the data that needs to be moved. They're already sort of wading through the diversity of the providers in a state. So, we might say, hey, we want everybody to use HL7 Fire APIs forever and ever all across this great country. But then the fact of the matter is the HIEs are in the real world. The HIEs are like, yeah, that's great, but I got these health systems and their EHRs can do it. Here I'm pulling like flat files. Here I'm, getting, some random interface to get this information. But the HIEs are that sort of pulling sort of this real world mess of data and making it useful and ingestible and, interoperable and semantic by sort of being ensconced in the local, in the neighborhood, right? Because this is really, really the benefit of the HIEs is their the way in which they are local, the way in which they are tied to the community, and they know what kind of electronic health system the long-term care facility has, what the post-acute care facility has, what the Indian Health Service has. Like they've sort of solved the problem of their area. So they're sort of like a eager partner ready to join us, but it doesn't always make sense to sort of speak for the government to say, okay, you have to use an HIE for this, because not every state has an HIE. Montana didn't have an HIE. So, you know, there's a problem with trying to sort of scale regulations around, hey, you have to use an HIE, but we're sort of getting to a point where we have a more thoughtful approach to working with HIEs. Like, we propose language to give providers sort of more points when you're looking at some of your MACRA, your promoting interoperability programs, that, hey, this works, this saves money, this improves quality outcomes, you can do this. That's proposed, though. I'm not sure I should talk about that. I'm not sure if I'd have to check on the comment period. It depends on the comment period, the extent to which I'm allowed to talk about that. But like, there's some signaling there that we're trying to think through how we can incorporate HIEs more. They're also an existing investment, right? They're also something that the ONC gave a bunch of grants out to way back at the, with the stimulus package, included a lot of high-tech funding for health information exchanges. So in many cases, HHS is sometimes looking at this as, look, here is something we've invested some money in and we want it to keep working. That's a little more ONC. CMS is a little less sentimental. CMS is like, we just want whatever works to help Medicaid providers and Medicaid patients. So those two philosophies sort of mingle nicely in the modern era, because what we're seeing now is it's not always just like every state gets their own HIE and that HIE is like going to be the HIE. Like, HIE is now a verb, right? It's not a noun anymore. So HIE is the verb is, yes, they might have a state HIE, but they also have, they're partnering with this vendor that does middleware. They're partnering with this imaging exchange vendor. They're partnering with this prescription drug monitoring program, and they're all sort of interacting. They're all sort of moving data, and it's all this sort of health information exchange with a lowercase HIE instead of a capital HIE. So there's really that ecosystem that we're really watching it mature.
Thank you for that. It's a great explanation. We have another question from the audience. Are you aware of any health information exchanges who have created or connected to advanced directive registries, especially during COVID?
Yeah. Yes. Well, I guess I'm not sure if they're done doing it. I know states are working on it. Obviously, your state sort of legal requirements need to be aligned, because it's not always that you can do it electronically. Colorado is very interested in doing this. There's an existing standard, an existing approach, and yeah, it's a good use case. It makes a lot of sense, and it also, just the metrics on it are really good too. Like, having the advanced directive like more available improves the family's experience. It reduces cost. The patient and the supporters and loved ones of the patient. So having that information really move helps a lot. And so the ability to sort of not only make it easy to enter your advanced directive information, but share your advanced directive information is pretty high yield. It does have some ROI to it as well. So it's not bad. Yes. And if somebody wants more information, I don't know, you can share my email. If I can help connect the dots, if you want to have a conversation with anybody, I'm happy to facilitate those conversations.
Thank you, Tom. We appreciate that. And we'll make sure we get that email address shared.
Of course.
To providers and facilities waiting to join Big Sky Care Connect, we often hear that, we want to wait until there's more participants, or we want to wait until there's more information. What would you say to those who want to wait, and what should they do really, and why? What's the ROI, the return on investment for joining now? Why should they join now versus waiting?
Well, I guess I have to remind myself of where you are with your approach to Medicaid, but Medicaid has a lot of data. So you're sort of not joining in, you're not sort of jumping into an empty pool. A lot of the approach can sort of fill that Medicaid data right from the start. So you get that, but there's also a financial advantage to doing it now, which is that the state Medicaid agency for the next year or so can support that a lot to remove a lot of the cost, but it is sort of a burning platform. Like there's really only a little over a year left where the state Medicaid agency can financially support some of that onboarding activity. And, you know, it's sort of, that's, you know, it's going to be a front loaded cost, right? Making that connection. But join now so that, you know, in, you know, a year or two, if there's, you know, some requirement comes around that, you know, more and more you're like, okay, Medicare wants me to do this, or my payers want me to do that. And it seems like, you know, it would be, you know, better for my practice to have joined sooner rather than later. The financial process will be better right now. I think if you sort of dig into a lot of the existing programs, like with Medicare and like some of the shared savings, like they already give you sort of a market for health information exchange. There's already motivations to participate in health information exchanges tied to MACRA and MIPS and the various federal programs out there. And, you know, there's more and more sort of doctor-led ACOs out there like Aledade and, you know, some of these other ACOs that are, you know, maybe tied to payers. That's going to result in a financial incentive to participate with a health information exchange, because, you know, they're looking at some of these shared savings opportunities where you partner with a, you know, hospital, a primary care, maybe a specialist, and you all get a cohort of patients, and you know, your goal is to maybe bring down that A1C. You bring down the A1C, or you control the A1C, and then you get a bonus, or you get a care coordination fee, or you get, you know, some sort of incentive. But in a lot of cases, you need that interoperable layer to do those things. So more and more value-based purchasing arrangements are really like, there's no new fee for service. No one is going to fee for service. Everything is moving towards value-based purchasing. And you could argue that it's sort of situational, that it makes more sense and less sense in some areas. But that architecture is needed for the future. And you might, like, it might be smart Montana-wise to do it sooner rather than later, because everybody really only has about a year left where Medicaid will be able to support about 90% of that activity.
Understood. And that's an excellent point. Thank you. Another question that we have is, can you talk a bit more about the value of having payers as part of the HIE community?
Yeah. Well, first of all, the payers get value out of this. They get, and it's actually right now, like this minute, they get a huge amount of value out of it, because they were in a position where, with various sorts of, it's not just the Affordable Care Act, but other regulations in the past, and it's going to get a little wonky here, have set for payers a medical loss ratio. So they have to spend 80% of their funds on paying claims and providing care. And then the other 20% is administration. What happened with COVID is they saw way fewer claims because people weren't coming in for elective procedures. So that went way down. And depending on if we're talking about, you know, healthcare.gov or Medicaid managed care or Medicare Advantage, they had to give rebates if they are, you know, not at that ratio, that 80-20 ratio. Also in that 80% bucket are quality improvement activities, and quality improvement activities could include health information exchange. So if you're a payer, sure, we'd all love to get a rebate. And as consumers, we would be like, yes, we would love to get a check. That sounds great. But as participants in a health information exchange, we're like, well, wait a minute, like this is an opportunity for the payers to make a significant investment in me, and they're sitting on this money anyway. This isn't hypothetical. This is happening in a few states where the payers are like, well, I'm gonna have to either give this as a rebate, or I can use it to, you know, support a thing I have to do anyway. So at this very moment in time, payers are very motivated to make some health information exchange investments. In some cases, that hasn't occurred to them. It's kind of a wonky thing to say, oh, by the way, I don't know how well you read the medical loss ratio regulations, but you're in a spot where you get to send that money right on over to a health information exchange and start doing cool stuff. Start doing some stuff with your care coordination, something, think through your NCQA requirements, think through, what you might want to do, is with your sort of care management, disease management interventions. So they have a lot of interest in helping out there. And the opposite is true too. They have a lot of information that we kind of speaking the HIE could be helpful for care coordination. They have, with their disease managers, their case managers, they may already know who has problems with social determinants of health. They might know who, because they have a special needs unit. They have people who know that this patient is homeless, this patient struggles with utilities, this patient, experiences domestic violence. So they have that information that, sort of depending on the nature of the information, would be helpful for the health information exchange to move to their primary care clinician, or move to the hospital, sort of, as appropriate and as allowable, get that information in front of the right eyes. So there's kind of a rich source of information, and the CMS interoperability regulation does make that information more liquid. It does put it in the patient API that all the payers that are sort of regulated by CMS have to follow. So that information, that payer information, is about to be more accessible. So there's an opportunity there to coordinate and get that payer data to help with the overall treatment of Montana patients. Like I said, I'm also available. Like if it's helpful, please feel free to share my email address.
I apologize. I went muted.
Oh, were you asking something? Oh.
Yes, I have another question. I'm so sorry. I was talking and then I guess I had muted at some point. What are the advantages to a statewide HIE in comparison to Commonwealth or care quality?
I gotta be careful here. I don't want to make fun of them. Like I said, the sort of the local connections are what you have. I think Commonwealth and care quality are great if you're only trying to just connect acute care hospitals to ambulatory clinics. Like if that's all you want to do, care quality, Commonwealth, they got you. It's a bit of work, but that's usually not a state's appetite for what they want to do. They want to do things with public health. They want to do things with the opioid crisis. They want to do things with payers and with other sort of parts of the state government and federal government. They want to do a diversity of things. Like what we found in Nebraska during the beginning COVID, that they needed to get school buses to kids' houses to deliver food because they needed the school lunches, and the HIE was there, right? The HIE is like, we have that data. They were connected to SNAP. They were connected to everybody. So I love the Commonwealth and care quality gang, but they can't do that. They can't sort of rise to the occasion and solve local problems the way state HIE can. So that sort of knowledge and familiarity with the local landscape and the partnerships are really what makes the difference, that they are part of the community.
Thank you. I have another question. What advice would you give to a state HIE to maintain provider engagement within the state HIE?
I mean, talk to them, ask them what problems they want to solve. And then, but sometimes it's also like you have to sort of present to them the possibilities. Sort of like what I was just trying to do there was also, it was a little strategic, that I wanted to sort of throw out ideas that here are some things some HIEs can do. If anyone listening thinks, hey, I would like Montana to do that, then hopefully somebody somewhere begins a conversation. But that's really sort of how you do it. Because there's maybe a bit of a failure of imagination in some cases where a provider may not know all of the things that HIE is capable of doing, or some of these use cases may not be things that you consider. So asking the providers what they want, but also sort of presenting to them, here are some capabilities we have. Like, are you interested in this? Like, I don't know how you generally interface if you work with the primary care association, or if you go one-on-one, if you have some big health systems. But it's worth talking to a lot of providers, sort of seeing what they want, with the overall sort of main philosophy being, give them something they want, right? Give them something that is going to help them do their jobs and reduce their burden and save money, like all these sorts of things. And you might be in a position where you need to do a little bit of education on, here are some of the abilities of an HIE, and here's some of the functionalities of what we can do. So it's really just about that conversation. Are you muted? Are you muted again?
Yeah, that was so weird. It keeps cutting out. I apologize. Thank you so much. It just goes. Anyway, that is it from our audience as far as questions. We want to thank you today so much for being here, for your expertise, for speaking with us. We thank you so very much. From here, we are going to break until 10:30. Is that right, Ben?
That is correct.
Okay, we're going to head to a break right now until 10:30. Thank you all. And thank you again to our guest, Tom. Thank you for your time and for your expertise. We appreciate you very much.
Of course. Thank you very much, and good luck.
Thank you.
I want to first offer my thanks to our sponsors and provide them a very special thanks because, really sponsoring not only this conference, but being involved in this initiative demonstrates their values and how important patient care is in this state, and their desire to work alongside us to truly make the communities in Montana as healthy as they can be. Thank you so much. I also want to note and special call out to the Department of Public Health and Human Services. Now, funding for our project is available through the high-tech funds, and that's been made available through the Department of Public Health and Human Services. I want you to note that the information that was shared today and any opinions expressed today are those of the presenters, are those of those that were attending. Please know that they were not opinions or information that expresses an opinion of that particular agency. I also want to give thanks, of course, to our outstanding panel members. Their expertise was outstanding and provided some very in-depth information in a variety of different areas. We had close to 30 individuals that volunteered their time to be with us today, and we really appreciate that. We heard from Tom Novak at the start, who really set the stage for today's discussion, noting the very important role and growing important role of HIEs across the nation. Leaders then shared their vision of what our HIE can do for the state of Montana. And HIE CEOs showed the impact that they're already having in their states nationally. We had providers that laid out the importance of patient care, particularly the stressing care coordination and the connection that can be made electronically with the health information exchange. And boy, we can't talk about technology without talking about security and managing that information and making sure privacy is protected. We hit that strong with our attorney and Deb, and we thank them for doing that. That's always on the forefront of our mind. And of course, the other thing on our mind is always COVID. Again, thank you all for the work you do each and every day to take care of the patients who are experiencing symptoms of COVID, testing COVID positive, or having a family member impacted by that. It's changing the dynamics in our healthcare system, and I thank you for spending your time with us and taking a break from that. And know that you'll be right back into the field again, providing that day-to-day care. We heard from a couple of speakers in regards to the important role that HIE has played in regards to disasters and the role we can play for pandemics. At the close here, we're going to offer the opportunity to speak with the folks that really made this conference happen. And that is the consultants from Health Tech Solutions who helped put this conference together and is providing consulting work for us and the expertise needed so that we're building the HIE that's right for Montana. So please join us in a few minutes to ask questions directly of those team members, questions from outreach providing to onboarding questions to technology questions. We'll take all questions, all types. And don't forget, the most important thing about a health information exchange is the data in the health information exchange. We need you to participate. So please give us a call. Let us get you on that pathway and in the queue to be part of the most innovative thing happening across Montana. Big Sky Care Connect's Health Information Exchange, our premier health information exchange for the state of Montana. So thank you and stay tuned.